Good afternoon, sir. I am Harsha. Presenting a short case. My patient name is Shweta, 17-year-old girl, resident of Nalagonda, educated till degree. She presented with chief complaints of pedal edema, facial puffiness since 20 days, and breathlessness as an exertion since 15 days. History dating back to January 2023, where she had a fever which was low grade, not associated with chills and rigors. No other specific complaints during this time. She was admitted for 4 days. She was treated. During this time, she was told to be anemic. Except for that, there was no significant history during that time. Since then, patient was having generalized weakness with on and off fever since January. But in the month of July, she had again one episode of fever. During this time, she had after a period of 3 to 4 days, she had facial puffiness, pedal edema, which was abrupt in onset. It was not associated with hematuria. There was no history of decreased urine output. And simultaneously during this time, she noticed oral ulcers, and she also noticed pigmentation, rashes over her face. And on probing the history, she gives history of hair fall since January 2023. And there was also history of joint pains. There was no history of joint swelling, no seizures, no visual disturbances, and she had a regular menstrual history also. And for which during this time she was admitted. So she was evaluated thoroughly for the pedal edema and facial puffiness. She was told that there was loss of protein and small amount of blood in the urine. Hence, she was told to consult nephrologist. After consultation with nephrologist, she was told to undergo renal biopsy, but they deferred for a period of 1 week. She didn't undergo any treatment for 1 week. Later, after 1 week, she had noticed that there was increase in breathlessness. So she again consulted nephrologist, for which she was referred to NIMS. On evaluation at NIMS, she was told to have some fluid in the lungs, for which underwent tapping, removal of the fluid. And she was also done some investigations. And she was also told that there was some amount of fluid along the heart. So presently, patient after treating with a few medications, she's symptomatically better, and she's been planned for renal biopsy. Renal biopsy. She's planned for renal biopsy.
So, based on your history, what is your thought process?
So being a young female with the systemic manifestations with oral ulcers, alopecia, means hair fall, alopecia, and malar rash with abrupt onset of pedal edema and facial puffiness, I would like to say it as lupus nephritis.
So, any class you guess?
I would like to keep it in either 3 or 4. Proliferative bronchitis.
Why this patient of the SLE developed rash?
Sir, usually it is due to either it can be due to hypersensitivity reaction, or it can be due to the skin manifestation can due to be per se deposition of immune complexes under the.
Why there is photosensitivity? So why this patient of SLE gets photosensitivity? Any thought process? I agree with you. These patients are prone for developing photosensitivity.
Hello.
What is What does this sunlight do?
Ultraviolet.
So ultraviolet rays exposures over the skin. What that cause? That cause exfoliations of the epithelial cells. Epithelial cells every day, some epithelial cells are lost, and so there will be exposure of the nucleus. So anti-nuclear antibody is there. So some immune complex reactions happen over the skin, and then that predisposes them for this hypersensitivity. Some reactions of eczema inflammation. So immune complex reactions over the skin. This is so-called photosensitivity. So your patient is fulfilling the criteria, clinical diagnostic criteria of the lupus nephritis.
Yes.
So under this criteria,
Sir, ACR ULR criteria is the latest one which we follow, sir. For that, she has to entry criteria is ANA, sir. ANA and more than 1:80 and head 2
that is
cells.
not there, ANA
No.
is not there with you.
Yes, sir.
Okay.
Apart from clinical criteria and clinical domain, there is involvement of like mucocutaneous and oral ulcers, and there is malar rash, sir, one is that. And then in form of pleuritis, like serositis in form of pleural effusion, and some, she was also told some pericardial effusion also was there. And next thing is involvement of the kidneys. There is loss of protein and active cell.
So proteinuria is also there. So we are thinking of probably.
She was also told for anemia.
Yes, anemia.
So hematological manifestations is also there. So what are the different other hematological manifestations in patient of the SLE?
So one is anemia, thrombocytopenia.
Anemia is very common. Most of the ladies in India are anemic.
Anemia usually autoimmune. Thrombocytopenia, leukopenia, anemia, mostly of hemolytic, autoimmune hemolytic anemia can also be there.
So anemia characteristic is so what?
Positive or false negative.
Yeah.
Most positive.
So Coombs positive hemolytic anemia. So that is the characteristic. Anemia can be seen anywhere. Otherwise, iron deficiency anemia is very common. Nutritional anemia is very common. So that is one. What else otherwise you can see in hematological parameters that will indicate no, probably this is we are dealing with a case of the SLE or lupus nephritis. Anything in peripheral smear or DLC count, TLC count?
So usually there will be leukopenia, sir, but there will be even neutrophil count also will be lesser.
Which count will be more suggestive of probably this we are dealing with the SLE. Right? So usually TLC count is normal most of the times. But if leukopenia is there, then it is good. But if it is not there, it is always normal most of the times. But what else would be relatively less in patient of SLE? Lymphopenia, lymphocytes count will be less, and then eosinopenia can also.
How will you investigate her?
Sir, apart from urine examination, urine microscopy, then we can.
What do you see in the urine microscopy? How does it help you?
So urine microscopy, we can see whether there is as it is proliferative glomerulonephritis, we can see active sediment, whether in the form of RBCs, WBCs, RBC cast, especially lupus nephritis telescopic picture.
What do you
Telescopic.
mean by telescope urine sediment?
Sir, it actually reflects activity of both active lupus nephritis and chronic chronicity. So we can see all types of cells, active and chronic, like RBC cast, WBC cast, along with that broad waxy cast suggesting of dilated pupils, that is chronicity.
Is what way? Proteinuria?
Yes, 24-hour urine protein excretion to be seen. So more than 500 is taken into the criteria according to ACR ULR. They can present with subnephritic rates and nephrotic range also. Then serological evaluation to see we need to do to include her into the criteria. Then we specific for SLE we can do dsDNA and anti-SNP And apart from that, we have to see complement level C3, C4 levels. Scientist method.
Which is more sensitive, more specific.
Sensitivity is anti-dsDNA, so specific is anti-sulfate.
Most sensitive antibody.
In
So anti-dsDNA and this. Which is the pathogen? What is pathogenesis behind this lupus nephritis? So whether this is anti-dsDNA, whether this is
Sir, it is-
antibody, ANA, which is causing?
It is basically autoantibodies against the nuclear DNAs and RNAs. So autoantibodies will be against both nuclear proteins basically.
So sir, all are almost nuclear, है ना? Anti-dsDNA, dsDNA, DNA is a component, है ना? Anti-nuclear antibody that is also nuclear. So lupus nephritis, what is the different pathogenesis of lupus nephritis? Why lupus nephritis happens?
So one thing is it is immune deposition, sir. There will be systemic disease. So immune complex deposition is the major
So
cause of
systemic
lupus.
disease we say because of multi-system
Multi-system.
involvement. So that is the systemic disease. Autoantibody formations is there. So which autoantibody is thought to be more pathogenic? है ना? So that is causing this lupus nephritis.
DSD.
DNA is thought to be a specific. Okay, that's fine. Have you heard the name of antinucleosome antibody?
Yes.
What is the role and how it is different from anti-dsDNA antibody? So read about all this, then also think of the different scenario. Why this is more common in female? Why it is more common in male? What is the hormonal things which is causing this predisposition? So there should be overall idea about the pathogenesis of lupus nephritis. So hormone things also play a role. There are so many autoantibodies are there. So which one is playing more important role in developing nephritis? So that is another important aspect. Then go about reading about all the stages of this lupus nephritis classifications. So you have told us you are thinking of either class 3 or class 4. So what was the basis of that?
So there is hematuria, there is proteinuria, so active disease.
Hematuria and proteinuria.
Yes.
So hematuria and proteinuria can be seen in which other classes of this?
It can be seen in class 3 and class 4. Some minimal in
No. So hematuria and what are the different classes of this lupus nephritis? Just tell me.
class 1, class 2.
Class 1, what is class 1?
Minimal mesangial.
Minimal. That
Minimal.
is called minimal lean lesions.
Minimal.
Fine. Go ahead. Second
Class
one.
2 is the mesangial expansion.
Mesangial expansion. So what is the clinical manifestations of this class 2?
So usually there will be proteinuria will be there, sir, but it is less than 1. There can be or there may not be hematuria. Sir. Minimal proteinuria can be.
So here is the condition where you might have the macroscopic hematuria, whenever mesangial expansion happens, particularly mesangial proliferation. Then you have the hematuria also, you might have the proteinuria too, not to that extent which you see in the class 3 and class 4. So when we jump into class 3 and class 4, what else other clinical character will come that will suggest, no, I am class 3, class 4.
Sir, there can be renal dysfunction, sir. Renal dysfunction in
Renal dysfunction, correct. Or
oliguria.
what else?
Oliguria can come.
Oliguria can come into the picture, renal
Hypertension.
dysfunction, hypertension will come into the picture. So then you go on the class 3 and class 4. And class 5?
Predominantly protein loss will be there.
So predominantly proteinuria, you think of the heavy duty of the proteinuria without other active sediment. So sometimes you suspect in a patient of the SLE, this is looking like lupus membranous. What is lupus podocytopathy?
Sir, in lupus podocytopathy behaves like an MCD, sir, but the patient will have ANA positive, but on immunofluorescence there will not be any immune deposits in them.
So
that
only
category.
podocytopathic changes would be there, and some degree of replacement of the podocytes and some degree of proteinuria as seen there. So in class 2, here without renal dysfunction, without hypertension, the patient might have the class 2, might have the proteinuria and microscopic hematuria in class 2 of the SLE, lupus nephritis, class 2 lupus
Then you
nephritis.
think of a podocytopenia.
Then you should also think of the bone cells. So it is not always any patients coming to you having the class 3 and class 4. You have to analyze in these prospects. What are the clinical few clinical pointers are there for to make the diagnosis of every class. So how will you approach?
How will you make a diagnosis of lupus nephritis only from the biopsy? Can you do that?
Yes, sir. So usually there are specific pathognomic cells like hematoxylin bodies,
Bodies.
fibrin thrombi.
But you don't see them very commonly.
Yes.
Hyaline
Hyaline
throm.
throm.
Hyaline throm.
Yes, hyaline throm. Pain. And usually in the biopsy of SLE there will be pleomorphic pictures. So some glomeruli represent one stage, another glomeruli can represent another stage.
What are wire loops in the biopsy?
Those are the impune depositions along the periphery of the capillary, glomerular capillaries. Specifically, it can be seen
Subendothelial.
subendothelial deposits.
Then subendothelial necrosis.
And can immunofluorescence also help you?
Yes, sir. Full house pattern will be seen, especially full house pattern, and sometimes C1q is specifically for
When will
SLE.
you say this is a full house pattern?
We have all IgM, IgG deposits, then C1q, then kappa
Definition.
lambda.
Definition of what full house.
So what does this indicate? Full house.
You should have three immunoglobulin components and
All
two
three.
complement components should be there. That is what is full house. What are the other situations where you can have full house deposits?
Sometimes in ERGM you can have full house.
1, 2. One more. HIV nephropathy. Atypical IRG and HIV nephropathy.
So you like to biopsy this patient. So every patient of the lupus nephritis needs to be biopsied. Yes.
If you have
What is the current KDO recommendation about the
if you
biopsy?
have a creatinine also which is elevated, there is microscopic hematuria, there is proteinuria of 3 grams, right? So what class you are dealing with clinically?
Will you answer?
Which class of lupus nephritis? you are
Significant
dealing with?
proteinuria, microhematuria, renal dysfunction, hypertension. Which class?
4.
Four, obviously, isn't it? So how does it matter if you don't do a
Why should you biopsy then?
We should also see chronicity also, sir. To chronicity,
You have to assess the activity also.
activity
Activity
and
Chronicity
and
and chronicity, yeah.
prognosticate and put a immunosuppression.
Yeah, so that is the purpose, and you need to have a baseline for
Baseline.
future comparisons. So that's why. Otherwise, you can treat the patient without even a biopsy.
Suppose the patient has thrombocytopenia.
Yeah, that would be
What
that's a
will do?
common situation.
Very common situation.
You have thrombocytopenia, and the rest of the picture is the same. So
Then
what do you
we
do?
can start
What will you do?
steroids. We can give steroids.
Steroids. So steroids will reverse thrombocytopenia, then do the biopsy. That's
That is a common clinical
Yes,
practice.
very common.
So, but KDIGO recommends, what about the KDIGO recommendation of global disease care? What they suggest? To do biopsy in every patient of the lupus, or there is some reservations?
Protein-
Have you read about this global disease recommendations which came from KDIGO?
20.
Go ahead, read about this. So they have given some options. Can or you may may not do, but definitely nephrologist, every nephrologist like to do biopsy.
Mostly.
Because,
Almost 100%.
100%. And there are reasons behind it. It is not that without reasons. Because rheumatologists are there in most of these criteria making guidelines. So they always they are scared of doing biopsy. But we are not. So will always be pro biopsy. We should do. The reason which you have enumerated.
If you have made a clinical diagnosis, I'm not talking now of this patient. Yes, and don't delay. Sure.
So thank you, sir. Thank you for a valuable time. And I think our students have gained a lot of knowledge and will have some confidence in facing the examination. A small token of gratitude.
Ice.
Sir, no, close your eyes.
Patients, transplant patients. He's a photographer, all our images. He's a
Oh my God.
second transplant. Today, one program career photographs. Any message you would like to discuss with?
No. It was always pleasure to be here. Whenever Swarnalata calls me, I get how I can miss this opportunity to come here. And this is all facing the question. It is not all interactive. You know what I think of. This is not asking the questions. You allow asking us the questions. That is also great for us. And then this is the mutual learnings. Whenever we sit together with these stalwarts like Professor Sapuja sir, Madam, Dr. N. Gopal Krishnan, many things I also learned simultaneously. So many questions I am not aware. So that is always, as much as you will interact, as much as you will listen to so many persons, because all these things are not written in the books. Otherwise, this examination could not have happened practically. So this is all experience comes over the years. Then you, with this small clues, you make the diagnosis. So this is always there, and it is always pleasure coming here. Thank you very much for calling me. Thank you everyone. Thank you Hyderabad Nephrology Forum for calling me and giving this opportunity. All are great friends. Raju, Dr. Rangathan is more there, Swarnalata. Always we all grown together. So always pleasure having this here. And the best part today was there. I was sitting beside Professor Sapuja sir. So that was all. Always an honor. Thank you very much. Thank you very much.
आपका जल्दी है सर आपको
Okay, right. I'll say something.
So you have half an hour time so you can just from our event.
I was just asking a question, not related to the lupus of this patient. There has recently been some literature. If you have a nephrotic and his PLA2R antibody strongly positive, some people suggest that you don't need to do a biopsy. You can apply a diagnostic label of primary MGM and start treatment accordingly. So, what do you think about that?
Yes, recent evidence suggests that we need not do biopsy for plaque or positive membranous nephropathy. We can directly start with the treatment.
Yeah, but should you fulfill some criteria before you do that? That's the important thing. Somebody said creatinine.
Yeah, creatinine should be normal.
Yeah, should be normal. True. The important thing is, see, there could be many. You could have a LAR2 positive, but you could have other reasons for that proteinuria also. So exclude all other conditions which could be associated with proteinuria. So like, in fact, diabetes mellitus is very important, a monoclonal gammopathy. So all other conditions that could cause a similar clinical manifestation. So because there may be two diseases that you're dealing with, not just the LAR2 positivity. So if you can exclude all those, if you can be sure that you have ruled out all those, then yes, you can manage without a biopsy. But I would admit that being nephrologists, most of the time we still are in the habit of doing a biopsy. We've not given up doing a biopsy because you do have valuable prognostication and so on. Yeah, so we still do a biopsy.
Unless
But-
somebody has got a thrombotic complication,
Yes.
already somebody on anticoagulation for thrombosis.
Yes.
And blood are positive, we continue treatment and then after some time again we do biopsy.
Yeah.
They
So-
recommend us to screen for secondary causes even if anti-PLA2R is positive.
Yes, yes. So if that condition is fulfilled, then you can. So there is a paper on this also, so you can read up that. This is one.
So what's your comment on critical analysis, critical comment on IS and RPS classification of lupus nephritis, histopathology?
So they have not included the vascular complications and interstitial compartment complications. That is
What are the vascular findings? The blood
Lupus.
vessel lesions in lupus?
Lupus, vascular findings.
There can be non-necrotizing vasculitis.
Like.
Non-necrotizing vasculitis can be there. So sometimes TMA also can be there in the vascular compartment.
And acute interstitial nephritis. Any other rare pathologies? A collapsing globulopathy can be there. Okay.
And a true necrotizing vasculitis is the rarest pathology. And of course, the commonest is just a non-inflammatory, bland vasculopathy with immune complex deposition there. That may be the commonest. So, necrotizing vasculitis, rarest, very, very rarely seen. So you can have 4 different kinds of vascular pathology in lupus, which is all not included in the classification.
What is the Bliss LN trial?
So it is the recent trial which came out in 2022, which included belimumab and recently FDA approved drug for treatment of lupus nephritis as an standard care of therapy along with
Belimumab, how does it help?
it inhibits the BAF B cell activating factor and thereby BAF molecule inhibiting the B cell stimulation.
So what are the other newer drugs?
Voclosporin, belimumab, then anifrolumab, anifrolumab,
Obinutuzumab.
obinutuzumab.
But these are all very expensive, but still they have to prove their superiority over the current.
These are still under trial.
Yes.
Nothing yet proven. But even in the belimumab trial, if you look at the analysis, they ultimately concluded that those patients who got cyclophosphamide, they didn't seem to benefit. It was the ones who got mycophenolate who actually benefited. So adding belimumab may be more useful in those who are on MMF rather than those who are on cyclophosphamide.
So can you quote the Indian study published in Kidney International on management of lupus nephritis? A study came from PGH Chandigarh. Class 4 and 3 lupus nephritis, comparing between
MMF and
versus low dose cyclophosphamide. So lupus nephritis is a high chance for being either short case or a long case in the exam. So you have to be thorough with that, and the same set of questions, 50 to maximum 100 questions. That's all. Just prepare the whole lot of it. keep on revising those things. What is SLIC criteria?
So SLIC criteria included like particular domains, 11 domains. Like it included described like each then
Prepare that one, prepare SLIC criteria. And in the histopathology,
They are
it is
the older
supposed to be.
ones. They are of 2012. The latest ones we discussed earlier, ACU last.
In the histopathology, which lesion is supposed to be more specific in light microscopy? For lupus.
proliferate
So proliferation you get in so many conditions now.
wild loop lesions,
Viral lesion you get in HIV also.
hematoxylin body.
Yes. Hematoxylin body is supposed to be more specific. And what is Ellie cell phenomenon?
So Ellie cell is the one which is in another tissues, which is equivalent to this hematoxylin body. It is engulfation of one cell engulfing the other cells, where there will be peripheral compression of the nucleus with another cell that is called.
What is the sensitivity of dsDNA?
So it is 88 specific, more specific.
Sensitivity not only around 50%, not more than that, you know. But ANA is more sensitive but less specific because it's a big list of conditions very, very positive, right? The hypocomplementemia, C3 is important or C4 is more important? Lupus.
So usually both are big pieces.
But which is more significant?
C3.
C4. Which is the other disease where there is hypocomplementemia C4? Apart from C.
C4
Cryoglock. Right. And what is the description of immunofluorescence pattern in lupus nephritis? Full house. Full house is specific for lupus nephritis or some other conditions also.
IRGN.
IRGN rare. IRGN now definition is C3 dominance. You are not supposed to get full house. If you get full house, Sami-Nasr criteria, it is not IRGN. IRGN is only C3 alone or C3 dominance.
HIV.
Okay. Yeah, lupus like glomerulonephritis or HIV, then hepatitis B virus. Okay. What is the animal model for lupus? Anybody? Animal model?
New Zealand.
New Zealand,
New Zealand.
black mice,
Black white.
and F1 hybrid, first generation hybrid of New Zealand white versus black.
Black.
And of course, there are certain MRL and other types of animal models out there. So, animal models for all glomerular diseases, just it wouldn't take more than 5 minutes, just list out and okay. So you might ask, what is the purpose of knowing animal model? How is it going to help me in my clinical practice? It will not help you directly in clinical practice, but that is the charm of medicine, charm of nephrology. You know, those days, you know, without animal models, the concept evolution would not have taken place at all. Now you have all molecular technologies to find out which cell is acting, what is acting. Those days it was only animal model. It may sound very primitive if you go back to the animal model, but without that we would not have nephrology, would not have evolved. So I have somehow got a lean for animal model. For every disease, the discussion ends with animal model. Sometimes starts with animal model. Okay. What is animal model for IgA nephropathy?
ADY.
Oh, good. So what is silent lupus nephritis?
The patient may not have a clinical symptoms or like urine may show bland, but there can be variability between clinical presentation and the
very rarely come
biopsy.
across urine sediment showing nothing but biopsy showing class 4. Yeah. So here comes a debate whether all patients diagnosed to have lupus should they undergo kidney biopsy or not. It's always a debate. So what is your stand on the debate? So ideal indications as per KDIGO guideline biopsy. Indications for biopsy as per KDIGO guideline.
Proteinuria with active serum and renal disease.
GFR or GFR. But what you say is right, there can be the discordance. What is lupus podocytopathy?
Sir, it is like MCD, sir, effacement of food process with lack of immune deposits.
Clinically, when do you suspect?
They have nephrotic range protein.
Nephrotic range protein, biopsy showing only MCD. So how do you treat that?
Treat it as an MCD.
Yes.
Treat it as
Since we'll also be leaving in a few minutes, just one question to the house. What is age-adapted definition of GFR? And why is there a need for such a modification? Anybody?
Physiological decrease. Above 40 years, every year 0.5 ml per minute GFR.
Decreases, yes. The decrease begins at around 30 to 40 years of age, that is true. So the reason why we need this modification is, if you go by the CKD classification according to GFR, right, over the age of 70, maybe 50% of patients will have a GFR less than 60. So they will all be diagnosed as CKD. So that seems to be unjustified. Right? We are over-diagnosing CKD in the elderly. So what has been suggested is that you should have a age-adapted GFR definition. Right? So you take 3 age groups: less than 40, 40 to 64, and above 65. And the GFR cutoffs in these should be more than 75 in the less than 40, right? In the middle age group, 60, and in the elderly age group, more than 45 GFR. So, to reiterate, in a person above 65, if the GFR is more than 45, the eGFR, and there is no proteinuria, no persistent proteinuria, that should be taken as normal. Right? Don't label it as CKD. So that is the age-adapted definition of GFR. So this is also something not very old, something recent, so you should be all aware of it. Because otherwise we are all over-diagnosing CKD in the elderly population.